Hi guys, I'm Dr. Mark and my seminar project today is talking about inflammatory disease of jawbone or osteomyelitis. Before I start, I'd like to thank Dr. Sermet and to excuse us for sending the presentation lately. First and foremost, we should define our subject, and it's an inflammatory of the medullary portion of the jawbone, which extends to involve the periosteum of the affected area. Here is the classification of osteomyelitis. First, suppurative. It could be acute osteomyelitis or chronic osteomyelitis. And there's granulomatous. Non-suppurative chronic sclerosing. It could be focal or diffuse. Chronic osteomyelitis with proliferative periostitis. And alveolar osteitis, dry socket. And there are special types of osteomyelitis. They are osteoradionecrosis, chemical osteomyelitis, osteomyelitis of newborn and infant, aka neonatal myocarditis. Acute osteomyelitis. It's a rare disease and is an infection of bone following an infection associated with teeth. The sources of the infection. First, periapical infections. For sure, as we talked before, it's associated with teeth. Periodontal pocket, acute gingivitis, penetrating and contaminated injuries, and tooth extraction. Predisposing factors. There's local factors, and they are fracture, radiation, Paget's disease, osteoporosis, vascular disease. And there are systemic factors: immunodeficiency, immunosuppressant patients, malignancy, poorly controlled diabetes mellitus patients, and chronic alcoholism and malnutrition. Clinical features. It's more common with adult and mandibular infections. The mandible is more prone than the maxilla, as vascular supply is readily compromised. Osteomyelitis in maxilla is more common in neonates. Severe throbbing pain, deeply sighted pain, swelling, malaise, and pyrexia. Gingiva is red, swollen, and tender. Involved teeth, tender and mobile. Intra and extraoral post-discharge. Regional lymph node enlargement. Paresthesia of lower lip and trismus. Radiography. It is normal in early stages and may demonstrate ill-defined radiolucency, as we can see here. In 10 to 14 days, sufficient bone resorption occurs to produce irregular, moth-eaten areas of radiolucency. Here. And this cropped panoramic radiograph of the right side of the mandible. You can see here suppurative osteomyelitis. Etiopathogenesis. Microorganisms that causes osteomyelitis. They are aerobic bacteria, Staphylococcus aureus, or hemolytic streptococcus, and anaerobic bacteria. They are pigmented bacteroids, anaerobic streptococcus, Porphyromonas, and Prevotella. Histopathology. In this picture, we can see acute inflammatory changes because of the neutrophils, of course, and bone trabeculae shows scalloping, bone necrosis with degeneration of osteoblast and osteocytes, and sequestrum. Chronic suppurative osteomyelitis. It is a low-grade inflammation associated with bone destruction, granulation tissue formation with little suppuration. Causes: Inadequate treatment of acute osteomyelitis after 4 weeks. Infection by weak bacteria, infection of a vascular bone, or radiation. Clinical features: tooth loss at the site of the inflammation, mild dull pain, jaw swelling, sinus tract formation, pus discharge, and shedding of sequestra. Sequestra can be felt by pole. Radiography: moth-eaten radiolucent area, multiple radio-opaque area representing sequestra. The second subject is chronic sclerosing osteomyelitis. As we remember, there's focal and diffuse. Here I'm going to talk to you about focal sclerosing osteomyelitis or condensing osteitis. It is uncommon non-suppurative inflammation with bone reaction around the root apex of non-vital tooth. It is a local response to a low-grade pulpal inflammation or high tissue resistant to infection. Clinical features: it occurs in young adults, commonly related to permanent mandibular molars and premolars. Asymptomatic, dull pain, large carious lesion, no vital pulp. Radiography: well-defined radio-opaque below apex. Here in this radiograph we can see an increase in radio density around the apex of the tooth.
Hello all, I will continue with the second type of chronic sclerosing osteomyelitis, is the chronic diffuse sclerosing osteomyelitis. This type represents a proliferative bone reaction of the jawbone to low-grade inflammation, and the source of this inflammation is through the PDL. The microorganisms responsible to cause this type are Propionibacterium acnes and Piptostreptococcus. Clinical features. The clinical features of this type are: it occurs in black elderly, more in female, in mandible and edentulous areas, and when there is uncertain dull pain, and this type is usually asymptomatic. Histopathology: it appears on the radiograph as a pagetoid or mosaic pattern. On the radiograph, the chronic diffuse sclerosing osteomyelitis appears resembling the shape of a cotton wool. Another type of unsuppurative osteomyelitis is the chronic osteomyelitis with proliferative periostitis, also known as Gar's disease. This type represents a reactive subperiosteal new bone formation in response to low-grade periapical infection or perifolliculitis or a trauma. As in the radiograph below, there is a new bone formation in the subperiosteal area of the mandible. Clinical features: it occurs in young adult of both genders when there is a mild pain and a non-tender smooth and hard bone swelling, and exclusively in lower first permanent molar. The radiography: as in the radiograph, on the outer surface of the cortex there is a smooth focal subperiosteal bony growth. Histopathology: when viewing in the microscope, this type appears as a fibro-osseous area. Alveolar osteitis, or the dry socket: it is a localized inflammation of the bone, occurs due to either a failure of a blood clot to form in the socket or a premature loss of the clot. About 1 to 3% of the cases, the dry socket occurs as unpredictable complication of tooth extraction, as in the figure below. When the third molar extracted, the blood clot failed to form in the socket, so that is the cause the dry socket is formed. The etiology or the causes of the dry socket are a failure of a blood clot formation due to poor blood supply, as in Paget's disease, osteopetrosis, when following radiotherapy, and in excessive use of vasoconstrictor in local anesthesia. The second type is premature loss of the blood clot, and this may be due to either excessive mouth rinsing or fibrinolysis by proteolytic bacteria. And the clinical features, it occurs most frequently in the case of third molar extraction, in difficult extraction with a trauma, and in smokers patients. And when there is intense pain, the tooth socket appears empty and dry, the jawbone is visible in the tooth socket, and bad breath and unpleasant taste, and when the regional lymph nodes are swollen. Histopathology of dry socket. As in the figure, the socket wall reveal a formation of a necrotic bone containing empty lacunae, and this seen in the histological section. Specific osteomyelitis, we have three types. The first one is radiation osteomyelitis, or the osteoradionecrosis. It appears as a bone necrosis due to irradiation of oral malignancy, and in case of endarteritis obliterans and the thrombosis of inferior dental artery. As in the figure, there is a bone necrosis. The other two types of specific osteomyelitis are neonatal maxillitis and chemical osteomyelitis. The neonatal maxillitis is a rare type of osteomyelitis, as well as the chemical osteomyelitis. The infection in the neonatal maxillitis occurs during delivery or breastfeeding, when there is a red, swollen, and painful maxilla with multiple sinuses, and in sequestration of developing teeth. While in the chemical osteomyelitis, the inflammation occurs due to incorrect use of medicaments and paraformaldehyde and phosphorus or mercury. Thank you for your listening.